Hi everyone, we are back for our Fertility Live Q&A tonight with Dr. Kenneth Gelman of IVF-MD. And he should be joining us in a few minutes, but I want to encourage everyone to submit their questions if you haven't already. We're going to be answering them within the next hour. Just any stage of any type of question you may have. All questions are welcome. And we are going to talk a little bit about some strategies, some things that have actually come up over the last few weeks as far as ways to prepare, especially if you've got maybe a few months to kind of do some preconception care and get everything rolling. And we'll definitely help you guys out as much as we can. Hey, it's Jude. Hello. And I think that we'll, continue to do these Q&As. I know for me, at least on a monthly basis, because I enjoy, giving you guys as much, hopefully, good information as we can to help everyone out. And if you have a particular issue that you've been struggling with, that's what we're here for. Dr. Gelman, I know, has at least over 20 years of experience or more treating fertility issues, PCOS, endometriosis, all kinds of things. And I've been practicing for about, a long time. I graduated in 2001, so it's been a while. So, and I've been working primarily with fertility patients since 2004. And a lot has changed since then, but basically just, the one fact remains the same, is that it's no less stressful now than it was, 10 years ago or more. So, I think the emotional aspect is very important. And then also working in with, helping like we do with circulation, with the timing of the cycle, and working as a team together. So let's see if I can find Dr. Gelman. And I don't know if he has seen us yet. Oh, he's texting me, but I can't flip over from my phone. So let me see here if I can look at on my watch here. Okay. All right, let me see. Oh, there he is. Okay, so let me go ahead and I think I did it. Okay, something's happening, so excitement. I think he's coming up here.
There we are.
Yay! How are you?
Can you see
We're
me?
here. Yeah, I can see you and hear you. So that's
Can't hear you.
You can't hear me? Uh-oh. Hopefully, can you guys hear me okay? Hopefully it's not my phone. All right. Let's see. Let's see if he's getting some signal issues. Hopefully. Okay.
I can't hear anything.
Oh, no. All right. Maybe turn your volume.
Can't hear.
Let me
But I can see you.
Turn.
That's good news. Don't know. I don't know why I can't hear any of you guys.
Oh, well, it's just me. But we can hear you, so that's good. Oh, thank you. You're welcome for this. Thank you guys for joining us. We will kind of, I think everyone's saying turn the phone sound on. Okay. All right. Hopefully it'll start popping in.
I can't hear.
Do you have your okay, you can't hear it.
I don't know why.
Phone is on silent. Yeah, it could be. Well, oh, now we can't hear him. Let's see. Now he's not being heard. No. Okay. Let me see. We can't hear you. Oh. Okay. We'll get him back. Okay. I think he has to fix his audio. We'll wait till everybody comes in. And in the meantime, hopefully my dog cooperates back there. He's not usually on these lives, but he got restless, and it's very hot outside. It's like I'm expecting any moment now to have my swimming pool start to boil. So he's a husky. He's not having that. So. All right, so let's see if I can find Dr. Gelman again, and we'll see if we can jump back in. Let me try to do an invitation. Okay, I did another invite. Let's see if it'll work. Hey, let's
How's
see.
that?
Better? Can you hear
Better.
me? Yay. All right, good.
We're better.
It wouldn't be a Wednesday night if we didn't have some technical issue.
Oh, always,
But I have
always, always.
a awesome. Awesome. Okay, well, everyone's coming in. Like, we haven't done one of these in a while. I feel like, I feel like it's been a while for me anyway. So during the pandemic, we were just doing so many Q&As, and it was pretty
This
much
is it's been at least a month or two, right? 2
been a
months.
little while, yeah. And I think everyone's been on vacation or maybe thinking about going on vacation. Now things are getting back to normal, so we've had a little break, but we are back now. And I hope that we can start with some things that were pre-submitted, but everybody who's joining us now, I guess let's do some introductions just in case you don't know who I am and you don't know who Dr. Gelman is. So if you could start by introducing
Yeah,
yourself.
Dr. Kenneth Gilman, again, Cooper City office with 2 other physicians there. And we're one of 13, I think, now. And then, we're part of a big group around the country, too. So, again, we've had a number of offices in Broward and Dade and up in Palm Beach County and even over in Naples. So we're around to serve the whole South Florida area. And it's a pleasure to be here.
And beyond, right?
And
Yep.
beyond, yeah. With telemedicine now, we're interacting with people all over,
Yes.
everywhere. I mean, not only in this country too.
Yeah. Yeah. And some people just prefer virtual now, I guess. It's the way of the world now. Even if you live in Miami, so still have that option. That's good. Oh, no. I think we can't hear you anymore. We lost sound. We can't hear you. Let me see here. Oh, now it's better. Okay. I was like, what happened? Okay, someone's saying they have their first appointment on Friday. Oh, that's awesome. Yeah, and it's a great time to, like I said, this is an opportunity to definitely pick our brains because we've worked together a long time and with each other's patients. And I know that in general, like you've pretty much seen every single scenario there is that can come about reproductively, I think. So I think it's a good time to pick our brains and let us know if there's anything else you guys need. So there's a few questions popping up. And for those of you who don't know me, my name is Farah Duro, and I'm a reproductive acupuncturist. I practice in Hialeah Gardens. And we also see patients who are going through menopause or also teenagers dealing with PMS and hormonal imbalances in general, pain sometimes from, period pains and then beyond and into pregnancy as well, treating migraines, back pain, and all kinds of things that happen with that. And obviously like working with patients going through IVF, IUI, and natural treatment as well, preconception care. So we'd like to today get started. I think, we've had a few questions early on PG, and that's one of the pre-genetic testing. It's kind of one of those questions. So I think we can handle both of those questions now. The first question was, can embryos be bad if they're PGTA tested? All 4 have ended in chemical, all 5 AA were normal, or 5 AA normal.
Yeah, that's a real good question. And we get cases like that, and it's very disappointing when that happens because, you're figuring that is the 100%, answer that, we're biopsying embryos, things like that. Well, don't forget, I'm sure your doctors explain to you, first of all, that it's about 95, they say 98%. It's about 95 to 98% accurate in terms of, how those biopsies are done, because don't forget the outside of the embryo where the placenta really is where the biopsy is developing. And, it may not necessarily correlate with the inner cell mass, although it's supposed to be, 95%, 98% accurate, which most studies are bearing out. But, we've had cases where we've implanted a normal embryo and it turns out it's not. But in this case, where how many transfers has she had?
It looks like four ended in a chemical. Yeah, so
Yeah,
four.
so there's something else going on there. That's not embryo related, in my view. I mean, I guess anything could be anything, but it sounds to me that there's more there that needs to be ruled out, like endometritis. This is some sort of discrete inflammation in the uterine cavity, something there that's not allowing the lining to, adhere to the embryo. Um, I'm sure they look for polyps, things like that, but this also could be some kind of immunologic implantation failure. Very difficult case. Um,
Mm,
but that person needs to not obviously transfer any more embryos, and we need to go back to the drawing board and do a complete evaluation,
yeah.
including other things, hormonal, immunologic, anatomic. To me, it
Yeah.
sounds like more than just the embryo.
Yeah. I mean, that's and definitely. Hopefully, you know, you can find resolution and so many other things, so many tests that can be done, like you mentioned, the endometrial biopsy or, any other stone unturned.
Yeah,
Do.
yeah. There's been a lot of talk about that in literature and over the years, and nobody really has an answer for sure about the immunologic system. There's some doctors who are very, very pro, treating the immunology system and using things, like intralipids or IVIG, things like that, which we do. Other doctors don't necessarily believe in that, but so some people try other things like platelet-rich plasma infusions into the lining, HCG infusions into the lining, Neupogen. That's probably something I would consider in this patient. But I would do a whole workup on that patient. If I was seeing that patient, I would start over, not transfer anything,
Yeah.
and see exactly what's going on.
And a question about blastocyst frozen on days too small for PGT. Why would it be too small, and does it affect quality?
Well, the embryo has to meet criteria for biopsy by the embryologist, um, before they'll touch it, because they don't want to necessarily disrupt an embryo and influence its ability to thaw out and obviously expand once it does that and implant, and it's in their judgment that, maybe this embryo, while it looked fairly decent on the inner cells, maybe the outer cells didn't look good enough to biopsy. So they're not going to disrupt it, but it's good enough to freeze. Like I say to patients, it's good enough to freeze. It's good enough to attempt a transfer of. And not every embryo, as I just stated, is necessarily genetically normal or abnormal, even though you didn't biopsy it.
Right.
So, it's very much like we did in the old days before PGT, when we didn't have the ability to biopsy them.
Yeah. Yeah, that's true. We come up to the point where everyone kind of expects to do genetic testing now, it seemed like.
Well, most people are doing it. I think it's the best we have, and there'll be other things coming down the pike, that'll even be better. Um, but most people are doing it. I think, with good reason, because we're doing so many frozen transfers, and people, particularly even young people who don't necessarily need PGT to help them implant embryos, are doing it because they may end up with supernumerary embryos that, you want to know, maybe you want sex selection for the second one, or something like that. Um, so, and at least you're paying for embryos that you think, with a 95 to 98% certainty, at least potentially are normal.
Now you can narrow it down a little bit too. If it's sometimes if you didn't test them and they didn't take, you didn't know really. I mean, it could have been everyone just would say, "Oh, it's chromosomal, probably." Well, now you know.
Well, yeah, that's true. And then, because you always assume that, but you can still assume it even with a PGT
Yeah.
normal embryo, like the first, question. But you're right. I mean, you would think that with that degree of certainty, you would be pointing at other things, like that first case that we talked about. So, we tend to point you in other directions, I think.
And there's another PGT, last question about that. How long after retrieval, PGT testing, etc., is transfer? Could we choose the month of the transfer?
Yes. And it's, you could do a transfer as soon as, the next month or two, because it's going to take time for you, obviously, to get a period after your retrieval. We got to wait for the PGT result. And then we have to, if you're going to do frozen transfer, you get prepped, and that takes a few weeks. So it takes you a month to 6 weeks to 8 weeks to get a transfer after your retrieval, once you know which embryo you're going to transfer.
And she also asked, are you guys pretty booked for transfers in January? I think maybe she meant, yeah, like, I guess, are you booked up until January for transfers?
I don't know.
Okay.
I mean, we close the lab in December, so we don't do any retrievals then. We're probably, we're at the point now, and we're in Miami at least, where patients that come to us, we can cycle them through Miami, and we can do 24/7. So anybody that comes in that's ready to go, or we prepare them and we get them going, and we can cycle them right through. And we have through till December, early part of December, to get you transferred. And then if not, we'll start you right in January. If you have embryos created in December and the lab is closed, we'll transfer you in January. The office I'm at, we will be doing that as soon as they finish the construction on it, which will be hopefully in a couple of months.
Okay, nice.
Yeah. So that person, if you want to come over and see us, we'll be happy to accommodate.
Yeah. Very good. And so this is questions about acupuncture. How frequent should you go during an IVF cycle? And I know we talked about this on a couple of lives. As far as, what we both encourage is, try to go a little earlier instead of just like last minute while you're, have like maybe a week until you're transferred. And sometimes we do have patients that call us up during that time, but we just had a patient with Asherman's actually, and she's trying to do an FET, and she hadn't been able to do it because she had a lot of scar tissue. We've actually been working with her with acupuncture, and now it looks like it's actually very encouraging that things are happening where she's able to do a transfer. Her lining is starting to respond. So we needed some time with her, and that patient is going to be different than somebody else who maybe could do, starting at like 6 weeks prior to transfer. But we usually recommend 3 months prior, if possible, at least once a week. And then we continue treating a little bit more frequently as, we get closer to the day of the transfer. Is that what you usually recommend with your patients too? Or?
Yeah, we do. It's for the first consult, we're always telling them about acupuncture and the benefits, that a lot of people, get a benefit out of it and they should start. So it's obviously a lot to do for these people. And we've talked about that numerous times, how much these people are going to actually need to go through besides their medical workup and their evaluation and their testing and meeting with the doctors and things. It's a lot to do. So we do encourage the acupuncture right away because it's going to help reduce their stress.
And I just did a little post because somebody asked, how does it work? Like, how does it help? So I just put a little post on our.
I saw that.
Yeah.
That was pretty intense.
It's a very, very busy picture there.
It's very busy and it's very chemically oriented. All those hypothalamic hormones and stuff. So if any of you are scientifically oriented, look at that. It's very impressive, actually.
It's really neat, and it's actually. I think
better than Xanax.
What's
it's better than Xanax.
Yeah. There's a lot going on when you do acupuncture, these markers now we can test for. I think those are really neat to see epigenetic markers. That's what they're doing in China now. So they're actually testing that, like what happens in the uterus when you have acupuncture.
Oh,
Pretty
really?
cool. Yeah. So those that's coming from that, and looking into the changes that happen. Also inflammatory markers, and what turns on and what turns off. And
Yeah.
there's inside.
Yeah, it'd be interesting. Have they looked at, I don't know if the answer to that, have they looked at HSCRP reductions or anything like that?
I mean, we do check our patients for that, and
I'm wondering if they actually reduce,
yeah,
if you're reducing inflammation in the body. I'm sure when you work on endometriosis stuff,
yeah,
that you probably affect that.
and looking into, I mean, like little details. Like first, they actually studied rats because the reproductive system is similar. So they looked at what do the ovaries do, and they actually added in electroacupuncture, and their LH actually went up. So they're seeing like more feedback from also the brain to the ovaries, and so they started replicating that, in their studies. And that, I think, like, we do see that a lot of times with our patients as far as how it affects you when you're actually under stress, or most people are under some stress, but actually you add IVF to it, and you add another thing to it, and it just keeps piling up. You have your work, and then you have your appointments that you need to go to, and then you got to go to work. You do all these things. So how does your body actually deal with that, and then also handling the hormones that you're giving it as well. And it's interesting because a lot of times the spouses will say, well, I think you should continue to go. Seem like you're much calmer, even though maybe the patient has noticed like a huge difference. Initially, they might actually kind of start sleeping a little better, and things just don't bother them as much. So I noticed
there's no question about that. And the other thing I was going to add to that is that we've talked about also yoga, specifically yin yoga,
yeah,
which whoever's not familiar with that is it's the gentler type of yoga where you're holding stretches.
yeah,
You're holding deep stretches for maybe 3 up to 5 minutes. You actually hold those stretches. I mean, particularly, it's an amazing thing what it does, and how much calmer you get, and
yeah.
obviously how much more flexible you'll be. And it's sort of the X factor in terms of aging.
No, definitely. Yeah.
Because one of the things we don't want to do, particularly in the fertility field, is age. So that's one of the things I would definitely add. And they're looking at things now to keep the ovaries from aging. So acupuncture and improving the hypothalamic hormones and improving the cyclicity of the ovary, very important. But they're also looking at. I saw that actually there was an article in the Wall Street Journal this weekend. I think Columbia actually. The guy up there, I forgot his name. They're looking at special drugs that they use now in cancer to, I think, immunologic therapy to actually help the ovary from aging and to keep it from going into menopause.
Why is it that the ovaries age faster than anything else? So it really is.
There's arguments pro and con. I mean, just to get, and we're getting off subject a little bit, but the ovarian aging thing, or some people think menopause is just natural aging and you shouldn't interfere with it. Mm-hmm. But now we're trying to, we obviously have a different argument because we're seeing women in their, 40s or whatever, who are approaching that situation and they want to get pregnant. So, we need to try to keep the ovary going longer, and there may be ways to do that.
Right.
Yeah. So, acupuncture is probably one of the things that can help because, if it's reducing all those counter-regulatory hormones and improving cyclicity, improving blood flow to the ovaries, it's part of the process, an important part of the process.
And length and telomeres, it's just very interesting. And I think there's much that still needs to be done, but it's funny that the science is now catching up to something that's been used for so long,
Right.
So
right.
And in general,
Right.
it's exciting to read about. It's very neat. So, yeah, if you want to geek out on that, like picture that I did, just stare at
No,
it for a little while.
that was really neat. You know,
It's very interesting.
and I encourage everybody to look at your website and look at that.
Well, thank you. Yeah, it definitely. I don't want to take credit. This was from the actual study. That's the picture that I posted. So I didn't do anything but post it. But
No,
some,
but it it gives you much more of a scientific explanation
yeah.
of really what could be doing this, what's going on there, and how important it is, not just do it.
Well, right. And when we talk about the immune system, if you notice in that picture, there's actually something that actually turns off to help the implantation process. So that was about, what happens during implantation when you're doing acupuncture, which means that the timing is important, right? So if we were going to do these points that we're doing at the transfer, we're supposed to do them during that time where things are actually happening, where you could actually be experiencing implantation right then and there, like within the next, I guess we could say 24 hours for sure. So the timing is important. If we can't be there for the transfer, we like to do it like the day of the transfer, like in the morning. Like some patients will just come to our office, we'll do
Yeah.
the post-transfer points, like actually in the office, and then we'll tell them just go home and rest. Like we're not, we don't want you to come back here after the transfer. I want you to just, take your time and rest and not do
Yeah.
anything. And not disturb the process that's happening, hopefully, and then within like 4 or 5 days, we'll see our patients come back for a follow-up. But it's and again, we're just still working on the same things, but they're very different points that we're choosing, and that's using those points in the study that was done so many years ago, that's been replicated, that originally was done in Germany and then it was replicated the United States. Those points are actually, like, their functions are exactly what was described in that slide. Like they are to help with circulation, with also prevention of contraction of the uterus as much as possible, and then also obviously we're going to focus on stress and being calm, but that's what's happening. So that's kind of why we do want to do those points like as soon as we can, because after that we can't use them anymore. They're actually not to be used until that person goes into labor almost.
Well,
So
yeah.
very, like, timing precise with that. And that being said, if you are doing acupuncture at your transfer, definitely, like, you want to go early enough to where you can get at least like a good 25-30 minute treatment in, and then directly afterwards, as soon as you can after the transfer, that second treatment will come into play. So
Yeah.
if, I know with sometimes it's difficult to actually have all those things happen where you can get acupuncture during that time. But if not, then don't worry. Like the day before even is fine. Well, we work with patients that are going to different areas that necessarily don't have access to acupuncture, so we're going to do the best we can that way. But yeah, I mean, I think if you really want to know like how it works and all of that, that's a good place to start. As
Oh,
far
that's
as
great. Yeah, that's great. That really kind of puts things really in perspective.
and
So
well,
so that puts things in perspective for people. I mean, so we're talking about how much it relaxes you and things like that, but there's proof. There's scientific proof right there.
yeah,
So it's very important to consider it as part of your treatment, I think.
yeah, definitely. And we have some questions in the chat now. We haven't been ignoring you guys.
Right.
We're like trying to get to the ones that were submitted before, and now we're over here in the chat. So I'm going to go to the very beginning here. And let me see. We had a question about, can you work out while doing IVF, like cardio weights?
Well, I would, you can early on, but once you start getting really stimulated, we encourage you not to do anything, excessively heavy. So particularly heavy weights or aerobics, things like that, because, your ovaries are getting a lot of blood flow to them. And your ovaries aren't static organs sitting there, and, they are floating around and they can twist. And you don't want to encourage your ovaries to twist on themselves. And that would be a surgical emergency, and you wouldn't like that very much. You'll end up in the emergency room.
How
Um,
that do you see the torsion?
yeah, torsion. It's called torsion. It's very, very painful and very disheartening to have that. So you don't want to be doing anything heavy duty towards the middle and definitely towards the end of that process until your ovaries, are cooled off and back to normal. So you're going to have to curtail the heavy duty stuff for a while, but initially in the first few days, you're fine.
Yeah, walking still is fine, right?
Yeah, but
Like,
even then towards the end, you gotta not really do a heck of a lot. Maybe light things, very light. No heavy lifting, none of that.
it's
No,
very,
no
yeah,
intercourse either.
yeah. It's hard to sometimes explain actually what is doing nothing because a lot of people are so used to doing things every day and working out.
Yeah, I mean, come home and
Yeah,
relax, watch TV,
veg out. You don't get that
read a
chance.
book.
Are there any safe supplements for inflammatory issues after biopsy results before FET? After
Well,
okay.
um, I think you're going to get probiotics most likely. We want to improve the bacteria. So I guess you're assuming you had some kind of inflammation there. You may have had an M-analysis biopsy where we look at the specific profile or map of the bacteria in there and see, do you have the good and the bad? A lot of people end up getting a M-analysis biopsy lately, sometimes after antibiotics, and we see that, a lot of them don't have the bad bacteria anymore, but they don't have any good ones. Because, you need the good bacteria, the lactobacillus in there to colonize the reproductive tract to help implantation. So, we'll be providing a lot of that. Any anti-inflammatory vitamins I think are good, like turmeric,
Fish oil.
things like that. EPA oil specifically, I think are important. Vitamin D. So those things specifically, I think are the important things.
There was
But your
uh,
diet, your diet,
diet.
your diet is very important because
Diet.
if your diet is poor, you can take all the supplements you want, you're going to have inflammation. So if you're eating a lot of sugar and you know overweight and you're pre-diabetic, you know that's going to affect potentially the amount of inflammation in your body.
And we talked about turmeric usually or curcumin. We like to recommend for patients with pain as well, like painful cycles, that sort of thing. But we usually just to hold off before an FET because it can be thinning to the lining a little bit. So we try to do that maybe prior to doing anything. But I mean, any other supplements you're taking, you want to just run it by your
Yeah.
doctor. Because,
Yeah, I mean, but specifically during your FET itself, once you're prepped, that's I'm talking about before.
yeah.
But once you're actually being prepped, you're going to get probiotics mainly. Vitamin D, fish oils, things like that. But before, like if you have inflammation right away, you probably want to have a very healthy diet. And if you're starting to prep for an FET, you follow what the nurse coordinator gives you.
Yeah, for sure. And yeah, nutritionists, you guys have a great two nutritionists there, right? One in Cooper City and one in Miami, or which is great.
Oh yeah,
Two,
yeah. The lifestyles consultants are fantastic.
yeah,
So you could work with them. They really they know their stuff and they do their job and they help us a great deal.
yeah. And it's important. So many times you hear like certain clinics will say, "Oh, it's not really important. Whatever you do, just do the medications and you'll be fine." And it's like we know that's not true.
Right?
It's like the most. If you have time, the most. It's never going to hurt to be healthy. To be a little healthy and get everything optimized as much as you can as partners too. As your significant other can do it with you. That's even better. So.
Absolutely.
There's a question about what is the reason a doctor might prescribe steroids like prednisone during an FET?
Well, there was some, I tend to use it in people, particularly with inflammatory problems or
Hmm.
with endometriosis, things like that, or implantation failure. I tend to use it, where it might be affecting, you know, some sort of inflammatory type problem that is causing the implantation failure. There's been some studies showing that it doesn't really do much. But I feel it does. I think prednisone in certain individuals really is a benefit to help improve implantation and particularly implantation failure. Empirically, I'm one of the ones that uses it,
And
but there are studies showing it doesn't help.
you taper off as you
I
get.
taper it off. I increase it if they're pregnant, and then I taper it off in the first trimester. So and the dose that's used is very low. It's not harmful
Okay.
to the baby. It doesn't cross the placenta or anything like that.
And what's a confirmation that someone can get pregnant by examination? What is the percentage?
What's that?
Oh, I guess they're asking about when you're examined, like, is there a test? Sort of, I guess they're asking, what's a confirmation that someone can get pregnant by examination? What is the percentage?
I don't know what they're talking about.
It might be like, well, I mean, when you first go in to do your first initial workup, like obviously an ultrasound and blood work and all of those things. But I guess they're asking what's the percentage. I don't know. Interesting. Yeah. Well, if you want to clarify, definitely type it in. But for sure, that would be to make sure your tubes are open and
Yeah, I mean, the usual things. I mean, I think, if you have your reasonable age, obviously, and you have regular cycles, you ovulate, your partner has sperm that looks reasonably good on at least in the initial analysis. You have an idea about timing. So these things I think are good prognostic factors. But there's plenty of people who have all that and they come in, they're still not getting pregnant. And that's when we got to investigate a little further and, help them out from whatever the cause might end up being if we find one.
Yeah, that's for sure.
Because, in the old days, we used to look a lot more with laparoscopies, things like that. We don't do so much of that anymore. We just, treat.
Yeah. Well, and definitely, it's there's interesting things now, that people can do at home too, when they're, waiting to get in to see you guys. But there's something called a Mira where it's a little vaginal sensor that tracks their hormones at home, which it's pretty cool. I've actually seen people, bring in their results and it Bluetooths to your phone. So it's I guess a step up from the BBT chart where people used to do the temperatures. Basically confirming if you're ovulating or not, like that's important, and one of the biggest things with PCOS is people that are not ovulating, and that's why they're not getting pregnant. So the minute you can help with that really turns on a switch.
Yeah, no, that's a good point. I mean, yeah, there are things out there and these apps, things like that. I think they help to a modest degree.
Mm-hmm.
But I think, people shouldn't overly waste a lot of time.
Mm-hmm.
The old dictum, if you're under 35, you may want to give it up to 6 months, trying. And then after age 35, I'd probably come in after 3 months or 4 months.
Yeah.
But certainly by age 40, I wouldn't give that more than a couple of months.
Yeah.
But it's always good to get checked out. And, like the question might be here is that, at least you're getting a doctor look at you and say, listen, things look okay. Give it, the doctor may say, listen, all right, you're fine. Give it, you're 32, give it 6 months. That might give, somebody a little bit more breathing room and relaxation, and maybe it happens now versus guessing at home and saying, oh God, am I doing this right? Is the testing really accurate? What does this mean? You come see the doctor, whether it's us or a gynecologist, it helps just to get an opinion.
Yeah, for sharing this. And sometimes we see where it's a patient who had been taking Clomid, for a while, and tried on their own. So, they come to us and say, well, I don't know why this isn't working. So we would send them to you guys, and they, just, it was as simple as like a uterine biopsy where they had endometritis, give them the treatment, and they got pregnant, sometimes. So sometimes it's that sort of thing that can be like no symptoms at all. It's overlooked a lot of times. But
Oh, that's overlooked all the time. Yeah, for sure. But you're right. They don't have symptoms, or they have endometriosis. They don't have symptoms sometimes. So it's just the question of sometimes just seeing the professional, and maybe being followed. Things aren't working out after 3-4 months. Come back.
Yeah.
Yeah,
sure.
It's easy to do.
And I think this might be okay. I think I'm this because I recognize the name, but someone's saying, if I'm currently pregnant and I'm lactose intolerant, should I still eat lactose products?
If they're lactose intolerant,
yes, I would stay away from lactose then for sure. Yeah. So
I wouldn't eat it.
yeah.
I mean, I would make sure you're working with a nutritionist during pregnancy.
Yeah.
Get the proper advice on that, huh?
You don't have to have dairy when you're pregnant. Like, that's definitely a misconception. Like, calcium's important, but it's in a lot of other products. So definitely there's alternatives,
Yeah.
And what's the scale of embryos? Could you explain it? Someone's asking.
Well, that's a internal data. I mean, that's not something, the embryologist, our head embryologist, keeps harping on the fact that, we as doctors or, patients always say, what's the grade of the embryo? And while they may give it a grade when they freeze it, it doesn't ultimately really mean anything. Mm-hmm. They just gave it a grade at the time that the embryo was frozen, and then when they thaw it out, it changes, expands. So, patients get hung up on that, and it's always nice, to see, when you get PGT results back and you look at the grade, oh, it's an AA embryo too, so, you figure that's a great embryo that's going to implant. It's a slam dunk. It's going to implant. That patient's going to be pregnant the first round, boom, boom, boom. And it may or may not happen, So we always have to be a little bit realistic about that. So even though it's an AA or AB or whatever, we've had plenty of pregnancies with BC embryos, very average embryos. Mm-hmm. Like today, I did a transfer on somebody, and when they froze it, it was actually her first. She had 2 transfers. The first one, she got pregnant. Very fair embryo, they said. Fair. Mm-hmm. Thawed out. She had a kid already. She came back. We did her second transfer today. Same thing. Embryo, fair, poor quality. Fair to poor. Well, maybe not poor. Fair quality, because they froze it. And we transferred it. It expanded and looked a little better.
Yeah, definitely. It's not a beauty contest. So sometimes the ones you least expect are the ones that work, right? So
you trust the embryologist because they have a lot of experience looking at these things. They know what to freeze and what not to freeze. Now, some places are going to freeze everything, or they're going to freeze them on day 3, and we're not going to do that. We're going to freeze them on day 5, and they're going to only freeze the ones that they feel can thaw out and eventually, implant.
Mm-hmm. And that's the other question, is how to know what is the best quality embryo, and that's when you're relying on the embryologist too.
That's
right?
correct. Unless you have a specific, if you have multiple embryos and you want the best boy, obviously, that's different. But otherwise, that's what we're going to write when we do our consults for, transfer, and we express to the embryologist, pick the best quality embryo available. And they have their internal data in addition. And they will know which ones they think will be the best one to transfer based on their morphologic data.
No, there's so many numbers. There's another, the AMH that comes up a lot. And that's the question is, how can you explain these numbers? What do they mean in cycle day 4? AMH 1.53.
Well, it's a decent AMH, but it depends on your age. So, if you're 30 and your AMH is 1.5, it sounds like a low number to me. If you're 38, 39, and it's a 1.5, that's a good number. It means you have a lot of eggs for that age. So it's age dependent. There should be, or your doctor should have a range there, not a wide range, a small range.
Mm-hmm.
So that's why we use Unilab, because they have a very small range for each age. So we know where it should be for, 30-year-old, 32-year-old, 34-year-old. Some companies, and I think Quest got a little better lately, they used to be, give a very wide range of normal, like from 0.6 to 9, So how do you know how good that is? If a 1.7, in a 30-year-old, is that a good number? Or?
Sorry, my husky's getting a little frisky back there. He's throwing his bone super loud, so sorry about that. There is a follow-up about FSH 7.7, LH 3.8, progesterone 0.5. These are all day 4 numbers. But we cycle day 4. I'm not sure her age, but definitely FSH like under 9 or 10, right, is what you're looking for. And it's usually done day 2 or 3, right? But day 4 is still okay, I guess.
Yeah, it looks reasonably good. So I don't know the age of the patient, but those numbers are definitely workable.
Yeah.
So I would say that looks good. Just, and whatever you're doing, you should have a fairly good prognosis with that.
Yeah, and your progesterone should be low because you don't produce progesterone until after you ovulate.
Correct. Yes.
So that's during your period. It's going to be much different than if you did those. Some people actually come in with the FSH done in their luteal phase, which I'm not sure. But
yeah, that's useless. So you want to try to do it on day 2 or day 3.
Yeah.
But FSH, fluctuates a lot. So you may have a normal one this month, and next month it may be a little out of whack. So it could vary, but that's why the AMH is a little more useful to look at, in addition to the ovaries and the age. So you got to look at a bunch of things at once.
Have you seen the AMH increase when someone starts supplementation, like with certain like vitamin D and that sort of thing?
Well, maybe slightly. You're not going to see it go from 1.5 to 4. But again, is it the supplements? Is it what the patient's doing? Is it the lab? Is the lab, that you're getting it done at, are they very consistent?
Yeah.
I don't know. I don't always know. But you want to think that the patients are doing better.
I think
that patient's 35, so your levels are pretty good. I would say you're definitely in the workable zone there. So keep it up, and hopefully you get pregnant very soon.
Definitely, and don't get hung up on the numbers because we see patients with low AMH.
No, that's true. So we've had patients younger than you with AMHs of 0.6 and 0.5 and 0.4. And then it's not always correct. You could still see patients stimulate a lot. I know Dr. Wood always has this famous case where she had a low AMH. I can't remember the number. And she got 22 eggs on this person.
Oh, wow.
So, yeah. So,
Oh, yeah, 35 AC. And I just passed the question. Okay. Just had my egg retrieved. 1 golden egg made it to blastocyst and just sent to PGD. What are the chances that it will make it?
That depends on your age. Depends on. Sounds like it was a decent embryo, and then they biopsied it, so it has a good shot of getting there. But it depends on your age, and But I'd say it's probably a 70-80% chance it's going to get there.
That's awesome. Yeah, and
yeah.
Really wish you the best of luck too with wherever you're going. That's really important to go into it with that mindset of like my body knows what to do and I'm trusting the process because I really think that it can definitely be defeating if you listen to a lot of negative self-talk, like, well, you only have one. Oh no, so like don't get hung up on that. And and even when you get pregnant, sometimes you start, going into the Google rabbit hole, like we talked about, and you start kind of typing in your numbers and seeing like
all the time.
good, and so it's so important just to kind of stay focused on that positive energy. Like, listen, we're going to get through it, and it's just step by step by step, one day at a time. That's what it takes. So there's a question about last question here. What are your thoughts on sperm DNA fragmentation testing?
Yeah, that's an interesting question. That kind of thing is useful, I think, if you repeat it and it still persists. I mean, obviously, if somebody has that, you're going to try to treat them with vitamins and antioxidants and things like that, or maybe the urologist will see that patient and, maybe they got a varicocele, maybe they think that's going to help. It's also a question of, whether you're going to do IVF or not. Obviously, you want to try to improve it as much as you can, because, there's a lot of sperm fragmentation going on there that it may contribute to an abnormal embryo and miscarriage, things like that, because, there's data about that. So you want to try to improve it. And, I think that's the kind of thing that you want to maybe see is improving before you go through an IVF cycle or retrieval, and or whether it does or doesn't. Maybe it might be better to use testicular sperm rather than ejaculated sperm because of that situation. So I think it's a good thing to do or consider if you're going to do IVF, or you've had recurrent pregnancy loss failures, and you want to look at something like that and see if it's repetitively there, see if it can be improved. And if not, you may want to consider, a surgical option on the sperm.
What's the normal percentage of DNA fragmentation? The question is.
So I think it's under 15 to 30%, I think. I can't remember the numbers. I think it's under 15%.
Okay, and they're asking about the normal viable sperm that is needed from a testicular biopsy for an IUI.
Well, you don't do IUIs with testicular sperm. You can't do that. You have to use testicular sperm for IVF, for ICSI. But IUI has to be ejaculated sperm.
And IVF, you could have even just a few, right? It would be. Is there like a?
Yeah. Well, you have to have some motile sperm. I mean, very little motility, at least maybe 0.5% or something like that, where they're at least twitching, that kind of thing. Especially even a testicular biopsy. So you can't use testicular sperm for any insemination procedures. You have to use it directly for ICSI.
Yeah. Good questions, guys.
Yeah,
awesome.
That was a good one.
They're just testing you.
That's a good one. Those are tough. Male situations are tough. Yeah, that's why we get the urology, special urologists involved, like the Ramasamy, or people like that. We should probably have him on one night with us.
Yeah, it would be.
He's really super, and he'd answer a lot of questions. He's like one of the. We're very lucky down here because we've got some really good urologists who are very highly specialized. I mean, the big guys are in Cornell, New York, but Ramasamy trained with him, and he's very, very, very good. And you have him right here at University of Miami, so it's great.
Oh, nice. Yeah, that would be great.
Yeah, I'm going to ask him. Maybe our next live we'll have him come on.
Great. There's definitely, definitely people that have questions about male fertility. Sometimes we don't answer them.
Yeah, we should. We'll accumulate those questions. So people out there, we're gonna work on that for you.
Awesome. Yes. Already you're getting some feedback here that they love it.
Yeah. Yeah. So you may want to consult with him In the meantime, Ranjith Ramasamy is down at University of Miami, Department of Urology. He's the chief down there.
Awesome. Um, and there's a question on if I'm on Doxy for 2 weeks with 7 days left, should I avoid trying to cycle? Or,
Yeah, I mean, you're on it for what? Endometritis or inflammation, depends what you're on it for.
yeah.
Yeah, but I would probably hold off till your infection's cleaned up.
Yeah, and let's see. I think that we got to pretty much everybody. And did I miss anything? I don't think so. We
Yeah.
had sperm questions. We had sperm. We had embryo questions. We got everything. So
I'm just going to mention one thing. There was an interesting article in, I think, Fertility and Sterility. It must have been a couple months ago. It looked at almost 1,000 patients, and it looked at their lining thickness, whether there was any cutoff or criteria that showed a higher or lower implantation rate. Interestingly, there was no correlation, zero, which was a fascinating study out of, so lining thickness may or may not be an issue.
Mm-hmm. It's what happens in the lining that's the bigger issue.
It's exactly right.
Very cool. Well, and that's a relief because I mean, so many people are.
It is, and it may be, and we're looking for that magic bullet to say,
yeah.
And maybe the ERA in certain cases helps look at that kind of thing, especially in a thin lining, maybe that somebody is receptive or not.
And so it has still to be like trilaminar. That's important, right? Or that it's the formation of it is still important, even if it's not as thick. Or did they look at that too, or just the thickness?
Well, I think it was a lining thickness only, mainly for implantation. They looked at strict success rates.
Right.
Yeah.
And okay, we'll get to the last two here. I think we have time for the last two questions.
Sure.
3 IVFs without successful results. What is your recommendation? If I have low percentage of, I think, of ATM, maybe is that AMH maybe? Or she put ATM, but maybe it was an autocorrect there. So
She had 3 IVFs, what?
Without success. And I'm not sure if it says low percentage of the ATM.
Well, low AMH.
H maybe, yeah.
Well, that doesn't necessarily mean you won't have success.
Mm-hmm.
If you're not stimulating, that could be due to the low AMH, obviously. But it doesn't necessarily mean the quality of the eggs are poor unless you're 42, 43, 44, and your AMH is low, the egg quality is going to be very poor in addition. So this is an age-related question that I can't answer without knowing more information. But so I don't really know what that person could do based. I have to know more.
Or get a second opinion for sure. Like if that's something that
Yeah.
I always think.
Yeah. So I don't know the answer to that one, but it's got to be something that's got to be looked at potentially. And if you're older and you have poor egg quality, it might be time to move on to egg donor.
And there's a progesterone question after IUI. Does it help? No hyperstimulation, letrozole only. I don't think you use progesterone, Dr.
Not usually, and not usually. The letrozole should handle it. You should have a good ovulation, from letrozole. If the letrozole is helping you and you're getting a good formation of a good follicle and you're getting good ovulation, your progesterone level should be fine.
Mm-hmm.
If not, then you need to maybe think about an alternative medication.
Mm-hmm. And how many failed IUIs before moving on? So 3 maybe or 4, or what would you recommend?
Well, depends again on age, on how long they're trying, and anxiety. There's a lot of factors there. Finances, could be, I mean, a lot of people use the rule of three. 3 strikes, you're out. Move on. Some people try it once. Some people do 6. You know, everybody's different. So that has to be an individual conversation with whatever that couple is comfortable with.
Yeah.
And it has to be, you know, looked at in terms of what their medical condition is at that particular time.
Yeah, definitely. And you said she's 32, trying for 10 months. And yeah, it's definitely an individual.
Yeah. I mean, 3, if you did 3 IUIs, I'd move out of that run. Because you're at a good age, somebody's at a good age now that they could create embryos and have their whole family there from possibly one treatment.
Yeah, for sure. And yeah, sometimes those embryos split. We have a patient this month who had 1 embryo transferred. She has twins now. So.
Yeah. I mean, that's that's not very common, but we do get that.
Yeah, it definitely happens. And I think we are wrapping up, guys.
Wow, that went fast.
I know.
That
okay,
was like...
One more question. This is the last one. Does IBS have any effect on fertility?
IBS? Not necessarily. I mean, you're talking about Crohn's or ulcerative colitis, things like that. I mean, I think your eggs are going to be your eggs. I mean, I don't think it's not going to affect egg quality, but it could potentially affect your implantation. But usually those people that we see are very well medicated by that time. And their IBS is quiescent, or they're on either Humira or I think, what's the other one, Entyvio? I can't remember the name of the drug now. And we leave them on it. So I have patients now with IBS, a lot of them, actually several, and they do pretty well.
And I feel like IBS responds really well to acupuncture. So
So they really do very well. You know, because they're under the care of the GI doctor, so obviously they're not going to have an active flare.
Yeah.
And be going through. So they usually have quiescent disease at that time.
But it definitely flares up under stress. So if you know, that's important to address it.
Yeah.
But I think, and also after transfer, we say don't push a lot. If you have constipation, just be careful because you don't want to have that straining and all of those things too, right? So take the things you need to take. Some greens first, fiber, probiotics, and all those are important. Gut health is actually a big factor in a lot of things. So, I mean, we overlook so many things about that, but it can influence many other issues. So, so that's a whole nother subject for another night.
Yeah.
So thank you guys so much. Thank you, Dr. Gelman.
That was great. I went so fast, I can't believe it.
Great questions, everyone. And if you feel free to reach out to us, to follow us on Instagram, and now we're on Threads. I have no idea what to do with that, but it's in like Twitter kind of, but it's like Instagram. I'm not sure, but we're working with that. So follow us and
look at her website so you can see all that that nice acupuncture thing there.
Oh, thank you. And to message us if you have any questions or concerns. We're here for you.
Yeah, nice to see all you guys out there. It's fun being here. We'll look forward to seeing you hopefully in a month or so.
Yes.
And I'm going to try to get the urologist on, and we'll look forward to maybe getting embryology on too.
Yeah. Oh, that'd be awesome. Yeah.
We'll have a few little guest stars.
Cool. All right. And one day you'll play your drums.
Yeah. Well, I'm going to produce a few videos.
Awesome.
As soon as the summer's over and my engineers are back and stuff.
Cool. That'd be awesome. Yay. Well, have a great rest of your month, everyone, and we'll look forward to seeing you again soon.
Okay.
Good night, everybody.
Bye-bye, guys.